So, good afternoon, everybody. So, at the outset, I would like to thank AIOC for this opportunity to give the keynote address for this paper which we had presented in the last AIOC. So, our paper has won the best free paper award in the optics and refraction. So, this is a study we did about learning curve in the construct of a smartphone keratoscope prototype for keratoconus screening. So, as we all know, I have no financial interest here. Keratoconus is a progressive bilateral and ectatic condition of the cornea, and advanced stage usually present with apical scarring, acute eye drops, and eventually all these patients require to undergo some form of surgery. So keratoplasty becomes the only option. So early detection and treatment to arrest the progression and prevent vision loss is very essential at this era. We can't think about keratoplasty. So why this study? As you all are aware, the prevalence of keratoconus varies among different population, and it is estimated to occur 1 in 2,000 individual. And surprisingly, the frequency, now the prevalence is more. And the Asian eyes, it is 4 to 11 times more than what we see in the Western world. The reason being exposure to allergens as well as some amount of racial differences. And the investigation modalities which are available are the placidos-based opticons, the pentacams, and the machines like oculizers. But all of these are solid organs. Means basically we are using these kind of things which cannot be moved. They are very bulky. So the early diagnosis becomes inaccessible to large section of population, especially the middle and lower income. So we cannot take these devices to people who really need it. So with this in the mind, the aim of this study was, we had a collaborated study with Microsoft software professionals, and an attempt was made to create a simple device using a smartphone based keratoscope prototype. So this was basically a research prototype, was in comparison to the keratron based topographer. So we developed a machine and we validated this model. So that was what the study was. So here we analyzed what was the steep learning curve and applied this modification with respect to how the device evolved. And second was the smart KC app. There's one app which was there. How did we modify it? Last but not the least, we also saw how this device can be having good sensitivity, good specificity, and repeatability as much as the other devices which are used for keratoconus screening. So the construct struggle. So first, the struggle was to create this machine. So we named it as Smart KC because we wanted to put it with a smartphone. So it was named as a Smart KC. We had to choose the Placido's design. So there were different varieties which were available, and like the ellipsoid ones which you see in the extreme left, this is too wide to be placed on the eye, whereas the conical one is very difficult to fix. So eventually we went ahead with a cylindrical type with a central ring that was created, which had rings extending from 4 millimeters, which was closest to the eye, to 15 millimeters, which is to the other end. Then we created it, but we had issues like the working distance gap, that is between the smartphone and the eye, and the gap between the cylinder and the eye. So these two gaps created issues of pictures which are not correlating the one with the keratron. So the Microsoft people, thanks to the collaboration, they used a simulation system which produced the regression formula, and that corrected these gap errors. So eventually we need not create every time a new model. Because of this simulation, we were able to see which was the best way to correct this gap. So once we corrected this, we used actually a simulating 7.8 minimum radius of sphere, which acted like a cornea. Then the second issues we had was about the tilts and offset. If the fitting was not very straight, then the closer it went to the eye, we used to get a overcorrection, and if it was away, then used to get a flatter cornea. So due to this problem, we were wondering how to tackle this. So we corrected this in the app by adding a central plus mark. So when we added the plus mark, only when the image was captured at the plus cross, it showed the correct capture, and we overcame the problems of this tilts and offset. So just to show you all how this machine works, can you please play this? And this is LEDs which cost hardly around 200 rupees, which is attached to a smartphone. Any smartphone you can attach this. This is a butter paper phone which is created of around 200 rupees. Overall construct of this smartphone itself is only up to 2,000 to 3,000. That's all, and it can be attached to any smartphone. So this is how the construct is of the smartphone. we go to the right end. And then this is the plus mark I was talking about, which will give the proper alignment of the placidos on the cornea. So once we know that it is exactly sitting in the center point, only then the image is captured. Otherwise, it does not capture. It gives us error. So now it is given here, it is in focus and sharp, and that capture happens. So once we get there, we go to the other end. So apart from this phone, the app has correction for the exposure, sharpness, and offset. So it takes into consideration how the image is captured. Once it is captured, this placido's image is then converted into a cropped image of the cornea. Then we go to the grayscale, and then it is an image lens. After this, we apply the basics of the subtraction, and then we apply the Zernike formula and fit it over and get the heat map. So this is how the heat maps are generated. So with this, we got this. After this, the last and most important aspect of smartphone was whether it works as similar to any other screening device. So we used pictures from the Smart KC as well as from the Keratron, whose prototype we had simulated, and we compared it by sending it to two blinded researchers, the doctors. They didn't know which image was this, and told them to detect whether it was keratoconus, non-keratoconus, or was it anything else. And when we did that, initially there was inter-eye variability which was observed, because the SIM-K values initially was captured for the 5mm zone. Once that was corrected to the 3mm zone, then the specificity and sensitivity greatly improved. So just to show you all, what you see on the right hand side is the Keratron output, whereas the other side is a Smart KC, and you can see that they are actually nearly similar. So we were able to get the comparable images. So the result of our study showed that the Smart KC had a sensitivity of 94.1% and specificity of 100%. And as compared to Keratron, whose actually sensitivity was good but specificity was less. Though we had issues with SIM-K being variable, but the inter-differences were not so much. So prior to this work, many people have conducted this, but there have never been such large-scale validation as we have done compared to the previous studies. So the limitation, however, is when this is just a research prototype what we had created, and we have to do this in a large scale. Second thing was, our data is only to a simple device. Now, if I say that, okay, I'll give it to you, you should be able to apply it to your device also. So we have to work on that. Third thing is, this app is collected by people who were trained. So if I have to give it to somebody without the training also, it should be user-friendly. So these are the limitations of this, but the study highlights that we have a Smart KC which is good, sensitive, and specific. So specificity indicates screening, and we are looking forward to modify this into a different type where we can use the AI and deep learning so that these images which have been taken, they can be captured and a data is created, and we come with its own algorithm where we can pick up the keratoconic disease. This is a modified prototype which has now been created. We have done in the last 1 year, where we have slimmered the cylinder so that it fits easily and there is no problem with the patient. There's one more video, sir. Can you just click on the video? There was a problem of fixation which now has been corrected here by putting two lights. You can see one right light which is for the right side when patient is looking from the right type of fixation, and the left one was for the left fixation. As we all know, when we take a topography from reflection based, if this fixation is not there, then we can get picture without the centration. The principal axis can get altered. So this is being corrected. So this is how it is. And now today, after this 1 year of our journey with it, presently now this whole thing has been made an open source, and from the prototype of research, it has now become a product prototype already, and worldwide interest has been created for this. Already people like Remedio, Glaucos, and Scott have actually come forward, and if you all are interested, there is a Remedio thing which has been put across here. Go into the trade and look, this prototype is actually available. You can look into it, see, and find out how it is when you hold it in your hand. So we are hoping that whatever we created as a research prototype gets into in next 3 to 5 years as an available low-cost screening device for anybody to use to screen keratoconus. So with this, I would like to end my talk. Thank you.
The whole machine has come into the market, or still in the prototype?
Sir, actually, what we did was basically it's a research prototype. So when I meant open source,
you said in the
that is Remedio people have taken this because it's an open source. Okay. They have taken the device idea, they've used the app, and they have modified according to them. So they have now coming out in a large scale, and they are actually working on. They are also collecting data. I think they have collected. So it is going to come out as a product, sir. But it is not from Shankara. It is from them.
Okay.